we will move forward to our next session, the EAPCI Next Gen Corner. This is a spectacular session with three EAPCI presidents, and in this session we will address important topics for our future regarding the training and certification of the younger generations. I would like to salute my co-chair, Rui Teles, and I'll ask him to introduce the first guest.
So, good morning, everybody. We are on the final journey of our annual meeting, and I have a great pleasure to introduce Aleide Schifo. She's the president-elect of EAPCI. We were together just a couple of days ago. It was a pleasure to join her. So the topic for her today is learning opportunities from online coaching to full fellowship grants. Okay, thank you. Good morning, Aleide. It's a pleasure to have you here.
Hi. So it's a pleasure for me to be there. I would have loved to be there in presence, and at the present time, after GISE, I'm in the European Bifurcation Club, and unfortunately, I could not join you live. So thanks, first of all, for this introduction and for the invitation. It's really a pleasure to be, even if virtual, with you today. So my topic is to talk about EAPCI education certification. Clearly, EAPCI has a strong interest in education and supporting our future leaders of tomorrow. This is really one of the most important points of our mission. And all the Emanuele and Darius, clearly, we are all aligned on this line. So let's first talk about EAPCI Fellowship Grant Program. What it is, EAPCI Fellowship Grant Program? Let's start from that. It's a 12-month training opportunity where the person who is getting the grant, and it's a grant of 25,000 euro for the candidate to cover his or her living expenses, will be going into an host center. The program works that clearly the host center has to be in another country as compared from the fellow. And this is a unique opportunity for the fellow, but in my opinion, also for the host center, in order to be able to mentor and support the future leaders of tomorrow. Why? Exactly for this, for one of the pillars of the mission of EAPCI and Ask Family to support the future of cardiovascular medicine. We have to invest in the future leaders if we want to have our field really to progress and move forward. Who can apply? EAPCI members and medical graduates from ESC member countries under 40-year-old. When there is first a call for host centers, and this is a possibility today to also give this information to the Portuguese potential host centers. If you fulfill some of the criteria to be an host center, please apply. The application is open unless there will be different timelines, but the application is open until 17 October, so you have still time to apply as host centers. And for the candidates, the call will be starting the 1st November 2022 until 15 January 2023. And also for the candidates, apply. This is a really unique opportunity. The result will be announced in May 2023, and the fellowship will start in July, December 2023. Just let's give a glimpse of the last 2 years. In 2021, we did add 68 fellow that applied to get the fellowship grant. And in these slides, you will see the distribution per country. The most application came from Italy, and followed by Spain, Egypt, Greece, Germany, Netherlands, Romania, and UK. And there were also 2 applicants specifically from Portugal. Another important point that we are trying to push is inclusivity. Inclusivity, it's geographical inclusivity, but also gender inclusivity. Unfortunately, in EAPCI, only 15% of the members are females, and there is a push from our society to have more women to enter in our subspecialty because this is the lowest number of women into any of the other association. And so that's why normally we allocate an equal number of grants specifically to women. In 2021, however, 28% of the applicants were females. What about 2022? Applicant per country, the total was 55, and again, Italy, I have to say, were most of the candidates that applied for the position, and mostly the geographical distribution was very similar to 2021. And this time we had only one application coming from Portugal, and we did a little bit less better, going to 20% only of the applicants being women. So we have room for improvement on this. The program, on the 2021 program, there was an overlapping. The two programs may overlap as grant allocation have been delayed due to COVID and some French anti-gift law limitation. So there were 68 individual applications, 19 women, 28 hosting center applications, and 9 grants awarded for the 2021. Indeed, for the 2022 program, 55 individual applications, 11 women, 14 hosting center applications, and 5 grants have been confirmed so far, with 2 additional ones under discussion. And there is this comment coming from Tatiana from Ukraine that is one of the winners of EAPCI grant of 2021 that give a glimpse, and I hope this is also an encouragement from the Portuguese young fellow that want to apply for this grant. Clearly, it is a unique opportunity to improve their potential as young specialists and to have a clinical and research experience in interventional cardiologist. And it was really a pleasure for us to give a specific help to these women colleagues from Ukraine. This is the fellowship grant, but last year we launched also new news, a new program, and a special thanks to Eduardo that was leading with us the effort together with also the committee, the young committee together with the women committee, preparing this proposal for this new kind of program, the online coaching. What is it, the online coaching? It is an online one-to-one coaching program over 12 months for young interventional cardiologists. Why? To enable the personal development of fellows interventional cardiologists, it is supposed to fulfill tasks both in the field of support for personal development, research, and practical tips. U is for young interventional cardiologists who are EAPCI member, and the pilot was launched in May 2022, and the period will be 12 months. And this is the winner, the mentee that were entitled for this program. And so you have the list of mentors that, by the way, were voted by the committees of EAPCI and the mentees that were awarded of the online coaching program that were merged with their specific mentors according to the request they inserted in their application. Online coaching program, clearly the history is only of 2022. We did add 46 applicants for this program. Again, Italy was the country where most applicants were coming from, but we did have 4 applicants this time for Portugal, also from Romania, Turkey, and then the usual distribution. Gender, 26% of the applicants were women. So the overview per country across the 3 initiatives, as you see, merging together the applicant for fellowship grants 2021, fellowship grants 2022, and online coaching 2022. As I said, and that's quite interesting, most of applicants coming from Italy, followed by Egypt, and then all the other countries. And there is also the specific for Portugal. We wish clearly to have more from Portugal applying to this initiative. The last slide is again another online course, because one of the mission of EAPCI is not only to address the younger leaders of tomorrow as physicians, but also our partner in our everyday life in CalLab, which are nurses and allied professionals. This is based on EAPCI NAP core curriculum and 9 modules online course with MCQ after module, and this is going to be launched, and the launch is planned in the first quarter of 2023. So thanks for your attention.
Okay, thanks for your very illustrative presentation that show how much EAPCI is involved in the training of our fellows, and how EAPCI supports with several programs their training. I'm going to ask Mariana Gonçalves, which has a grant actually. She's working in Toulouse now. I pass over to her so that she can ask a question.
I cannot start without thanking you, Dr. Alaid, Chief Dr. Rui Teles, Dr. Eduardo Oliveira, and all the members of the EAPCI team, because you have done a wonderful work and for giving me the opportunity to go abroad and pursue my career in interventional cardiology. It's definitely a unique opportunity, and it's a motivation for the young fellows that finish a period of intense learning during the internship to have this opportunity to go abroad and meet other ways of working. So thank you very much. It is definitely a wonderful work. I had the opportunity to know the other fellows that already won the grant this year and the last year during EuroPCR, and this is a unanimous opinion about your program. My only question, after thanking you for the work, is do you think there is a way also of motivating the hosting centers? Is there a trade-off that the fellows could offer to the centers so that this would increase the number of centers that receive this kind of fellows, that do this kind of programs?
So there is, as I said, this online application. Clearly, the center has to meet some criteria. So they have to state the number of procedures they are doing, because usually it is per topic. So the grant is per topic and has to meet the capability of the center and also the request from the fellow. The characteristics that the host center has to have are clearly stated if you go online. And we do have a call open by 17 October. Clearly, there is the willing to have more centers to enter into the program. And this is a push that we are trying to do. And it's a push that we can do also today for Portugal colleagues. So if your center has numbers and capability to host one of our fellows, please apply, because we really need the work of all of us to push the field forward. And by the way, thanks to you to have participated, because you are our future, and you will have all our support to really go into education, and specifically to you, because as we have seen, unfortunately, we still have a low number of women into interventional cardiologists. And as I always say, it's not because of women and men, but because we cannot lose any talent. And we need also the women in cardiology to enter in the subspecialty and then to keep working in our subspecialty. So this is a special call for all of you, and thanks to have participated. And I'm really happy that you really enjoyed your experience.
Thank you so much, Alaid. It was an honor to have you in our meeting, and we will invite you again soon, for certain. Thank you so much.
Thanks to you.
Bye-bye.
So we will move to our next lecture, which will be done by Professor Emanuel Barbato. Professor Barbato is the EAPCI president. Is a good friend of our society. Is an outstanding interventional cardiologist and a prolific writer, and he's an outstanding clinical researcher. Emanuel, many thanks for your participation, and please tell us about the strategy of EAPCI for education and certification for the future.
Thank you, Eduardo. Too many kind words. So much like Alaide, I also would have really wished to be there in presence. Actually, unlike Alaide, I missed GISE, I will miss Bifurcation Club, and I will miss APIC as well for health-related problems. Nevertheless, my voice has recovered a little bit, so I hope you will receive it well in the room. I will share just a few slides. You will see that some of those are, in a way, repeating concepts. There is some degree of overlap between this lecture and the previous one, but it will give me the opportunity just to re-emphasize the important concept that Alaide has just conveyed, that I fully endorse and fully undersign. Actually, when she said that we are aligned, the three of us, she couldn't say it better. So this is actually our structure, our mission and vision in one slide. So let's start from our mission. It's known, but it is useful to remember. We are here to reduce the burden of cardiovascular disease through percutaneous cardiovascular intervention. And the visions we have is to improve access to all percutaneous cardiovascular interventions. This is from the healthcare perspectives and from patients' perspectives. One of the bottom line, the fil rouge of my term, is really to have or to improve an equitable access to percutaneous cardiovascular interventions through different initiatives that will be deployed over these year and a half, 2 years of my term. To advance the knowledge in education, standards and research, to continue to advance transcatheter valve interventions. These are our main 5 pillars that are perfectly aligned with the 5 ESC pillars, starting from membership. EAPCI, it's an association done by all of you, actually. It's really having the, let's say, the head in Europe, but the feet are really in the ground of each and every national society and working group. And APIC is one of the most important contractor, I would say, of this association. As you will see during the discussion, there will be the opportunity to mention this. Education is our main objective, and we try to achieve this through webinars, certification, grants, as was mentioned by Alaide, fellows courses. Researcher publications, we have important assets there that we developed. Congresses, of course, we have the 2 top-in-class congresses, the EuroPCR in May and PCR London Valve in October, November. And finally, advocacy, which is perhaps less known among the activities EAPCI does, but still extremely important, because it is thanks to advocacy that we first identify the areas of unmet needs, and based on this analysis, on this appraisal, we can then deploy the initiatives for the near future in order to boost our energies and resources in this or in the other field. But we can discuss about this during the discussion. This is our EAPCI community in a nutshell. More than 7,000 individuals. As Alaide said, 16% of women. This is a massive unmet need. We are all working on that. It's not fair that this message comes only from Alaide for obvious reasons, but I can tell you, I fully support this as one of the main goals in order to increase really the number of female colleagues. I know that out there are many more than EAPCI members, many more in the communities that are practicing interventional cardiology. We want to mobilize these talents and ask them, encourage them to join the community and be active within the associations. Nurses are extremely important for us, 5%, and 17%, this is really our legacy, 17% of young or training in interventional cardiologists. Overall, 192 countries are in a way represented within EAPCI. So it's really a global association. This is just to present you the executive officers. Of course, you have met already with Alaide, and then you will hear the Darius Dudek, who's the immediate past president. And the three of us are nicely working together to achieve the mission and objectives I just mentioned. Together with us in the executive board, we have the secretary, Robert Byrne, and the treasurer, Louise Buchanan, and two PCR representatives, Vijay Konadian and Martin Gillard. Also here, nice even representation, men, women, and also from different countries, with the exception of the two of us, me and Alaide coming both from Italy, but that's more an exception than a rule. This is actually the scope of the educational offer of the European Society of Cardiology, which is a lifelong learning from training to continuing professional development. This is what applies to general cardiology, but as a matter of fact, it is mirroring what is happening within our association. So starting from training, we have a curricula. We have already published last year the core interventions curriculum. We are about to publish, and again, Rui Teles and Eduardo are among the leading author of this important effort. We are going to publish the structural heart disease intervention curriculum. Based on this core curricula, we are developing training program, either online and on-site. Of course, we value our textbook, which is also a source of learning from for our young interventional community and not only young interventional community, adding on that also a large educational portfolio. Of course, we have to verify that this learning is effective. We do this through our certification programs that is, of course, deployed once a year. It's ready for the core intervention core curriculum. It's about to be launched also for the structural heart intervention curriculum. And then the continuing professional development is announced and warranted by recertification programs and postgraduate academic programs. This is our educational offer in a glance. Courses and events, I already alluded to EuroPCR, which is our flagship course that is normally delivered in the month of May. Then PCR London Valve, which will be in 1 or 2 months from now. Within the EuroPCR, we host the EAPCI PCR Fellows course, and we are working for next year to have an EAPCI PCR Fellows course also in structural heart interventions at the London Valve Congress. And of course, a wide offer of educational webinars that are not only inspired by the core curricula, but also from state-of-the-art and consensus document that our associations, with the help of the national societies and working groups, is developing. Publications, the PCR EAPCI textbook. This will be one of the assets within the membership benefit. The core curricula I already mentioned, the one in PCI, the one in structural heart disease intervention, and the one for nurses and allied professionals. They also published one, and based on that one, they are now launching shortly the online educational course that Alaide has just mentioned. Again, we develop the know-how, and then we deliver the knowledge through these channels. I will not go back to this, if not to say that it's true what Alaide said, that most of the candidates are men as compared to women, but we as association have a mission, is to give equal opportunity to everyone. And as much as we can, we always strive to give 50-50 allocation of grants to men and women, irrespective of the fact that women are applying less. Of course, we need to work on that, and we need to have more women applying. And we hope that by giving this strong signal of support, we will manage to encourage more female colleagues to join us in these activities. The online coaching program, I will not spend a minute on that. Alaide already did all on this. And I will use the last minutes of my presentation to just discuss a little bit more on the EAPCI certification in percutaneous coronary intervention, which is the one ready, and that we normally host online at the end of the year, around December. It's done in 2 parts, and I'm sure again that Rui and Eduardo, who've been very active in the developing of this curriculum, can tell more on those of you who are interested in Portugal to apply for this. There's a theoretical part where the members of the Training and Certification Committee have hardly worked to develop multiple choice questions. As I said, it's remote, online, in December it's done normally. And we are developing a number of webinars that are aiming at preparing those interested to attend the certification, preparing those colleagues to have a successful pass of this exam. And then there will be a part B that is more certifying the practical part, which is basically keeping track on the cath lab activities. And finally, there is this ongoing EAPCI country mutual recognition process. Our dream, our vision and our dream is one day to have your EAPCI certification in percutaneous coronary interventions being recognized at the same time in all EAPCI countries. For the time being, we are working with a pilot number of countries who agreed to voluntarily work on a mutual certification. So on having these EAPCI certifications automatically recognized in those countries participating, which will not be, for the time being, a legal diploma automatically recognized by the, let's say, mutual governments, but at least it will be recognized on a scientific societal level, which is already a first step to what we would like to achieve in the near future. This is finally an EAPCI map of interventional cardiology on training and certification. This is work from Rado, forgot his last name, I forgot for that. I apologize for this.
Parma?
So, sorry?
Parma.
Radoslav Parma, you're right. Radoslav Parma. Rado did an excellent job in querying in different EAPCI countries whether there would exist a structured training program in intervention cardiology. These are the preliminary results. And as you see also there is a massive unmet need. There is still a lot of work to be done, as only in 55% of the cases we have a legal and common training program. In peripheral heart intervention, it goes even worse, less than 26% of the cases. Structural heart intervention, 20% of the cases. In acute stroke, 16%. So again, like we did in many, many other areas, we first make a diagnosis. We are doctors after all. Once the diagnosis is done, then we try to deliver the therapy the best we can in the areas where it is most needed. With this, I thank you very much, and I'm happy to take your question if there are any.
Emmanuel, many thanks for your lecture. We have some questions for you. Anna?
Okay. Hi, Professor Barbato. Nice to see you again, now in a different context. First of all, I would like to thank you and congratulate you for your excellent presentation and all of your work in the EAP as a EAPCI president. Regarding education and certification, there are no doubts that these initiatives and these topics are of crucial importance for the standardization and improvement of practice regarding interventional cardiology across the European countries. And of course, they are the basis for the country mutual recognition process. I just have a question for you. So regarding the face-to-face training events that you talked about during your presentation, do you have now a structured or a defined idea what will be these face-to-face events, or some other next steps for regarding this part of the training?
Well, Anna, thank you very much for your questions. By the way, for those of you who do not know what Anna meant, Anna is one of the awarded online coaching program, and she's been. I had the fortune to have Anna assigned to me So that's why I meet with her on a regular basis once a month. So to come to your question, what I have to say is that for the time being on site, we have the EAPCI PCR Fellows course. We're going to implement within the on-site educational program the EAPCI PCR Fellows course at London Valve. Most likely we will have in the portfolio also the Krakow course, especially for colleagues working in eastern part of Europe. And what is new, but it's still under discussion, and hopefully by the end of my term, we'll manage to launch at least the first edition. If not, I will hand over this with pleasure to Alaide, which is a number of educational models that we would like to organize at the Heart House, like in the good old days, in areas that are not yet covered from the existing educational offer. So what we are thinking of is to organize selective modules of 1.5 days, specifically directed to early career intervention cardiologists. I don't use any longer the word young, because everyone can be young, but I guess it is more appropriate to discuss about early interventional career cardiologists who would come and have a boost in training in specific topics. I don't know, treatment of tricuspid valve rather than treatment in calcified coronary disease. That will be more or less the model we are thinking, and hopefully we will be able to launch.
Emmanuel, thank you so much. I will ask you to stay connected for the closing session. Thank you so much. And Rui, I'll ask you to present the next speaker.
So I have also the great pleasure to introduce the past president of EAPCI, Professor Darius Dudek, which is, of course, our past president since João Silveira, Eduardo, and myself worked with him at the board, and it was a great honor for us to work with you, Darius. I welcome here today. Going to talk about a topic that is developing a stimulation-based educational pathway for the next generation. Good morning, Darius.
So good morning to my colleagues. I miss EPIC. So as Alaide said, also I was at GISE, but I needed to come back today to Ireland when we do the simulation. And this will be the first time my presentation on this topic. So I will show you the experience of our international team, which I hope will be stimulating for the young colleagues in EAPCI and also for Emanuele and Alaide to incorporate for the next core curriculum for simulation and robotic trainings. So first of all, I would say that we are in the era of 45 years after the Andreas Grinzing, when he started in the regular CAD lab, I would say with the nowadays for me old-fashioned methods, and it's time to change the CAD lab into CAD lab of 21st century with the coronary and robotic interventions based on CT, on modeling, on preparation, and even including the remote proctoring and remote procedures. So as we know from some publications, we know that in the technology, no one is constructing the jet without the simulation and preparation. So rather it is the computer simulation, creation, and then the real manufacturing of the, for example, the flying technology, including the aircrafts and jets. So that's why in 2021, we prepared with colleagues the article on robotics, imaging, and artificial intelligence in CAD lab to be ready for this transformation. So I will show you now that we need simulation, because if we look for the number of cardiologists, interventional cardiologists, we know that it is a shortage in many countries, and still it is the problem for interventions like primary PCI or stroke intervention, and the hybrid procedure for the high-tech interventions. So in the near past or earlier, there were just training like we see here, but many of our education tools still are based on this rather old-fashioned operating teaching. So we think that is a time to go and to use the simulation, which is now matured with the 3D printing and the advanced imaging for more education, for research, and creating the new approaches and training the operators. So first of all, with our simulation, we are working on the real cases. So we have the CT of a patient with after the procedure or before the procedure. Then we do the 3D printing, and then the 3D print model could be, we can implant, for example, the TAVI valve and to use the real catheters with the high resolution cameras and X-ray systems to really mimic the behavior of catheters and valves in human body based on 3D prints, CT-specific patients models. So that's what we want to analyze, and we need to understand that if we say simulation, very often people are confused because we have the different models for simulation. We have the digital simulation, when you can digitally simulate procedures. You have the digital simulators, when you can do, like in real life, some procedures. And we have the flow simulators, when you have, for example, 3D printed models and the flow beating heart, moving valves, and you can do your procedures like in human, and the anatomy is very similar. So that's why we say that we use with our team in everyday practice nowadays, this simulation for education, for the training of experienced physicians with new techniques and devices, and we do new techniques and devices for research purposes. So that's what I said. It is the education, clinical experience, and research and development in our hands. So first we started during the pandemic time in 2020 with the Polish-Italian cooperation, when we were using the raw data from the CT. Then it was the segmentation, it means the delineation of the appropriate structures. Then it was the computer modeling of those, for example, TAVI patient with coronary arteries. And then we printed models, and then we did with Antonio Colombo the first simulation of the procedures on the 3D printed models. Then we added the advanced imaging with the augmented reality, and we're trying to use this computer simulation, 3D printed model, and bench testing for our simulation of the procedures. This was our first publication based on advanced imaging, when we were checking what about the depth of the TAVI implantation and the coronary access after the implantation. And it was clear that if we go lower, so it is better for coronary access. When we go higher with our valve, you have the impaired access to coronary arteries, but you can have the better parameters, so it means lower gradient of the neo valve implanted. Then our bioengineers, they created a lot of different color models with the real, as I said, CT-specific models. And they were for purposes of analyzing the coronary ostia and coronary sinuses for the future access after TAVI implantation. So this is the example of the modeling with the 3D. So you can see that based on the real patient CT after the implantation of the surgical valve and the TAVI valve, so valve in valve, you can see the all anatomical relations. You see the coronary arteries, and you can do analysis of the space. So nowadays we are working together on this 3D dimensions around the valve implanted for series of patients with the CT scan done after implantation, before implantation, to predict one, coronary occlusion, the risk of coronary occlusion, and the second, future coronary access after TAVI implantation and TAVI in TAVI or TAVI in surgical valves. And this analysis of the three-dimensional are very important for this prediction. So this is another example of another publication on this advanced CT-based technique with the modeling and the color mapping of the structure, which is helping to understand better your future procedure after the implantation. As I said, we did with Italian group in Maria Cecilia Hospital with Antonio Colombo mainly 2020-2021. The first models which were printed aorta, aortic ring, and also printed valves because we didn't have the access to real TAVI valves or real catheters because it costs a lot of money. So this was the first models with the printed TAVI valves after the implantation and based on the specific patient CT. And this was modeling done in that way, which I described. And we're simulating in computer the depth of the implantation of TAVI to look for coronary access for future interventions. And also we are working not only on the depth, but also, of course, on commissural alignment to have the best position for valves to have the future intervention possible, especially after valve-in-valve procedures. During these procedures in Italy, we found that we can have the internal access to coronary artery, but also we can have the external access. And for example, we find the new techniques. We say the vertical Judkins 6. Nowadays, when they do the training, a lot of people say, okay, you can take the Judkins left 6. Many cath labs, they say, we don't have 6 because it does not exist. It's not true. You should have, it's rarely used. But for some anatomies, it's very easy, 1 second access to coronary artery. When you go from internal, you can spend many minutes, even hours to get access. Also, we found the snake techniques that you can go around the valve, or you can use for many procedures the internal mammary catheter, based everything on this bench models. Usually in literature, you hear that it's recommended to use the downsized catheter, but it's not necessarily true, and we'll prove in next publications in 2023 that we should think in different way about the coronary catheter selection for patients after TAVI, and everything is based on the simulation models. Moreover, we did additionally the mixed reality pictures, so we can not only see, as I said, on the modeling and simulation with 3D printed models, but also we use the augmented reality for computer simulation. And also in the meantime, here in Ireland, we developed the flow model. So we have a model which is pumping, and the valve leaflets are moving, and you can see the coronary arteries and aortic arch is real based on the CT specific model. And the valves this time are real valves, and we have the access to surgical and TAVI valves, so we can really simulate the inhuman environment. This is the model which we developed recently, just this month. And you can see that it's a flow model. You have the femoral artery access, and you have also the radial access. And we have the high resolution cameras, which are looking for our intervention, and also we can see in X-ray. So as I said, with these new models based this time on real TAVI valves, we are simulating again these techniques for internal and external access, and describing now the newest paper in preparation for step-by-step approach how to do the best CAS after TAVI implantation, and especially TAVI in TAVI. Moreover, we are using the technology with our bioengineers for simulation of the leaflet movements. Augmented reality is by definition is a reality which is giving something what you cannot see in real life. And fluoroscopy is a great example, because in fluoroscopy you see only the frame of the valve, but you are not able to see the leaflets and the skirt and moving leaflets because you don't see this in fluoroscopy. So that's why if you look in augmented reality on your iPhone owned by the HoloLens technology, you can easily overlay your picture in fluoroscopy, where is the skirt and where is the leaflet zone movements. And so that's why this will be very important, because many of operators, they don't know where it is the intra-annular or supra-annular valves leaflet fixation. So that's why nowadays we are saying that you have the red zone when it's a skirt, but also you have the green zone when it's a functional zone, and it depends on your technique. That if you miss, if you are behind the leaflets, you can have the coronary access, and we are working on this. As you see, we described the new functional zone. So this is not only experience on the TAVI and coronary access, but also for robotic PCI, we found the useful techniques with the 3D printed model. So here is the robotic arm connected in CAD lab. However, this time it was not the patient. However, we had the 3D printed model of coronary arteries and arch. So I can assure you that all movements with the robotic arms are the same like in humans. And then we can try the new techniques. And for example, with colleagues from Italy, we found that we can do not only movement with coronary delivery system or wires, but also with guiding catheter, we can do CAS, and we are trained on these 3D printed models. Moreover, we go for advanced procedures, so we can simulate very difficult bifurcation stenting, decay crash, or different techniques. So that's why we are very fast after the starting with the robotic system in 2021 to be very experienced with the advanced procedures. So we started to do the left main stenting with ultrasound guidance, with decay crash immediately after starting the robotic story, because we are trained on the 3D printed models. Finally, in June this year, we did in the United States the first remote PCI on the 3D printed model. So one center was 5 miles away from the simulation lab in the hospital. And in the hospital, we connected our 3D printed coronary arteries. And I did with American colleagues the remote PCI. This is the example. So the console is like 5 miles away from this model. And we are doing the wiring, and we are doing the step-by-step decay crash, let's say, for left main. So it was possible and feasible, and we are absolutely ready to do in human, when only technology is approved, to do remote PCI, including the bifurcation stenting and decay crash. Also, we pay attention to this simulation for education, and that's why we have students from Jagiellonian University, and they come for simulation for interventional cardiology to look how to do simple coronary angioplasty, what is the wire, how to stand it. And also we use for the explanation of structural heart intervention, including the TAVI. So that's what is happening in Jagiellonian University. And finally, in April this year, rector asked me to open the Digital Medicine and Robotics Center in Krakow. And we opened not only for cardiology, but for all medicine departments in our university. And now we are progressing with this 3D modeling and computer modeling for all departments. So in conclusion, I would say that based on our experience, simulation could be the new standard for medical education, training and research with innovative techniques and technologies. Advanced imaging processing is currently necessary for proper procedural planning and intra-procedural monitoring, and integrated with simulation could replicate the real standard operating room conditions. So I would say that now we are moving from the Andreas Grinzing of the traditional X-ray CAD lab into more non-invasive imaging with CT, MRI, and other modalities to prepare the procedure, and then even to do some the coronary intervention, maybe also structural knee in future with the robotic support and even remote. So it means that we are moving from the X-ray environment to non-X-ray environment, and we think that this is a real future. This is everything possible due to EAPCI and grant cooperation of not only our, but other colleagues' association within the European Society of Cardiology. Thank you very much.
Thanks a lot, Darius, for this window that opens a bright future in our area. I'm going to hand over to Afonso Oliveira to ask you a question. Okay, thanks.
Thank you, Professor Dudek, for being here with us, and your impressive presentation, very futuristic. My question, we can use simulation, as you've shown, to study how devices interact. That I think it will be very useful when we start having a lot of patients for valve-in-valve procedures to understand the interaction between device and patient anatomy. But my question is regarding education. Do you see, we have many similarities with pilots, aeroplane pilots, and they are required to undergo regular training, simulation training. When they receive a new plane model, for example, they have to undergo a certain amount of hours in simulation training. Do you think in our future we will also be required when we are starting a new procedure, or even for long life recertification processes? Do you think we will be required to have this specific time on simulators where we can be exposed to rare complications, and we can do perhaps rare complications, 100 of them in a week? Do you think this will be a reality?
I think that it is reality. I like that you say that my lecture is futuristic. However, I want to emphasize that this is the real what we did, and we are trained based on these models with the robotic PCI and TAVI and coronary access. I think that it should be and it will be mandatory For example, I was 1 year ago pushed by the company because I wanted to do the new valves, the new TAVI valves, and I needed to do 5 procedure on simulator, which was from Simulant from Italy. And this is the global company which is using this model, and you need to do like 5 cases before you start in human. And then I started to do TAVI cases. Moreover, I noticed at EuroPCR or TCT that when you have the very rare interventions like, I don't know, goose snaring, they don't use very frequently this, so that's why they train people in these rare cases to be more practical, more experienced when they experience this in the CAD lab. And once again, I want to emphasize that we opened in Jagiellonian University this Center for Digital and Robotics because I'm showing that it is not the future, it is not just the near future, but it's present, that all these techniques are useful for training of experienced even operators, training for unexperienced operator. And what we do today here, we are just working on the new valve-in-valve concept of implantation to have the better new technology. So in all fields, I'm showing that it is the real, and this is the clinical examples which are really translating into everyday practice.
Darius, thanks for your outstanding participation. Congratulations for your outstanding work. This is a completely new field. And you are truly a pioneer. We will soon invite you again, and next time, hopefully, you will be with us face to face. Goodbye, it was a pleasure.
I would love to come, so sorry for this, but it was just interaction with Jesus, so this is the only way, but certainly I would be happy to come here in person.
Thank you so much. So we will move to the next presentation, and I'll ask Rui Teles to tell us about the concept and the usefulness of the mutual recognition process.
So, first of all, thank you for this opportunity to talk about the certification that we are developing together with several countries on behalf of EAPCI. Now, the chair of this committee is Radoslav Farma, and I'm going to talk on his behalf in a certain way. So the certification was launched in 2018 by during Andreas Bambach presidency by Darius Dudek, Eric Van Bellen, and myself. And the certification in interventional cardiology has 2 parts, the theoretical part and the practical part. Just to let you know why it's important, because actually nowadays EAPCI has members all over the world. So it covers, and it has a huge importance in our practice around the globe, not just in Europe. Although we should be proud, because if you think about the number of members per million population, we are very good in that position here. This was already covered by Emmanuel Barbato, that we launched a survey to understand what are the certification needs. Actually, there is only certification or training program in 22% of the countries, and in what regards a national exam for this sort of certification, you have 21% for PCI and just 9% for satellite disease. So that means that there is a gap that we have to cover, and most of the candidate or the members that answered that they would receive very happily the possibility to align their certification at the national level with the EAPCI in 3/4 of the cases. So, going back and very briefly, EAPCI certification as part A and B. Part A is theoretical part and B is the practical part. Part A is based on the EAPCI core curriculum, and for each one of us, if we want to apply for it, we have to be based on this core curriculum, and we'll have to study through the EAPCI textbook that was mentioned and honored here yesterday, by the scientific documents that are issued by the EAPCI. So they are ESC scientific documents, the guidelines, and all the papers that are usually delivered and published at the Euro Intervention. And finally, by a series of webinars that were launched this year to support the certification, a total of 7 webinars. The part B is the practical part. We have implemented the CAT lab pathway, and we're going to implement the country mutual recognition process. I'm talking about that in a moment. The CAT lab pathway is a pathway in which each individual applies by himself. He has to have a mentor and the head of department approval, and he has to insert a number of procedures per trimester during his 2 years of training. There is no minimal requirement regarding the number of procedures, but we have to at least to capture what is actually the level of training that each candidate is performing. The practical part can be also and will also be launched in 8 pilot countries that are volunteers. One of them is Portugal. We are working on that now. The goal is that APIC will stand as the representative of EAPCI here for the Part B. So if APIC states that that candidate has fulfilled all the requirements, the candidate will complete the practical part by the APIC statement. And what does that mean? That means that he has to reach a certain level of competence in several areas, namely, for instance, femoral puncture, radial puncture, left main PCI, left saphenous venous graft PCI, and that level of competence goes from level 1 to level 5. Level 1 is just a theoretical competence, and level 4 and 5 are levels in which the operator is considered completely independent. And having said that, and to conclude regarding the certification, country mutual certification, what I can say is that we are eager to launch it in Portugal so that each one of us that has already reached the Part A certification in Portugal can be recognized by APIC and be the first ones recognized around Europe with the full certification, full EAPCI certification. Thank you very much.
Very outstanding. Any question from the panel?
No, just a commentary from someone that is not in Portugal. I think it's one of the most important initiatives that you do is that this uniformization of the recognition of the subspecialty, because if we are promoting people to go outside to do a fellowship, they should have easy access then to return to their country or to stay 1 or 2 years more practicing in a legal way, in a consistent way, recognized from all the other colleagues. Thank you very much.
Just to clarify, with the mutual recognition, does this mean that you may travel around Europe and work in any place? What is the practical implication?
So the goals of this certification are to harmonize training around Europe so that everybody has a certain level of competence, at least a minimum level of competence in several areas that are requested by us. And that will allow that you have a certification. That certification does not entitle you to be a subspecialist. That is, in several countries there are entities that do give that certificate, that sort of title. This is not that title. At this stage, it's a certification that allows you to travel around Europe so that you can state that I was trained in this way and I achieved the level of competence in these areas, so that you are considered a good operator. It's a certification of excellence in your practice. So that means that, for instance, Marianne is in Toulouse. In France, lots of candidates fellows that are working there, they are not going to stay there. They want to go somewhere else. So they will have that certification that will document their proof of training in their institution. But that does not imply that you are entitled to be a subspecialist. That depends on each country level.
So this means that the countries maintain their independence on the approval of the certification, but the process allows for a uniformization of the standards of classification of training
around Europe
and theoretical. Okay, great.
But for example, we in our case in Portugal, what are the differences between this certification in the APCI and the formal certification by the subspecialty? I mean, do you see in the future being equal?
We are working in a process that will allow so that the Ordem dos Médicos will recognize the certification as enough to be entitled as a subspecialist. But anyway, Ordem dos Médicos is the one that is going to issue that title, but the proof of excellence in this case will be just the certification, the EAPCI certification is enough. But for now, for the time being, you have to fulfill the requirements that we have here. Okay, I think we should close the session and go for the closing.
We should close the session. I would thank again the presence of our international guests. It was truly an honor to have you three here in this spectacular session on EAPCI topics. Rui, it was great to be with you co-chairing this session, and thanks to the panel and all the colleagues in the audience. And we will move to our final and closing session of the meeting. Thank you.
Thank you. Thank you.
Thanks to you.